Hello, this is Dr. Francis recording the lecture for intestinal obstruction. It's found in your Lowy book under chapter 42 on page 952. Intestinal obstruction can be a potentially life-threatening condition. The major concern is the fluid and electrolyte deficiency and early recognition of deterioration of the patient's condition. Some of the things that can occur when a patient has a intestinal obstruction, or otherwise known as a bowel obstruction, is hypovolemic shock from not enough fluid being processed through, or bowel strangulation. Nursing assessment begins with a detailed history and physical, determine the patient's location, duration, intensity, and frequency of abdominal pain. Many times the abdomen is very, very firm and distended from the inability to pass any gas through, and it just begins to accumulate in the abdomen. Intestinal obstructions can be due to colorectal cancer. As you studied, colon cancer is one of the #1 concerns in America, related a lot to our diet and people just not having the workup that they should. Other things are adhesions. Adhesions are due to perhaps previous surgery, and then there's been unusual cell growth, and the cell growth has blocked the abdomen. A hernia or an outpouching that has blocked the way, penetrating injury such as a stab wound or a gunshot wound. Intussusception. Intussusception is when the bowel turns upon itself and that tunneling of it kind of blocks it. Impacted stool. This can become an issue, especially for the elderly or people who are on chronic opioids. And a paralytic ileus, which we had discussed previously, where the abdomen becomes the motility in the intestinal tract becomes frozen, either due to post-op or some other type of immobility. Intestinal obstruction in children is the telescoping of the intestine called intussusception. And a hernia is when portions of the intestine protrude onto another part. Approximately 60% of the low bowel obstructions are caused by a malignancy, cancer of the colon. 20% are caused by diverticular disease. Diverticular disease is along the lining of the colon, or is diverticuli. And when they become inflamed and swollen, they can block the way. And if the swollen, when they are swollen, it's called diverticulosis. 5% are as a result of colonic volvulus, where they also can have like a twisting upon the bowel that doesn't allow for the passage of gas or stool. The most common cause of adult large bowel obstructions are neoplasm. And the neoplasm just means abnormal growth, and that can either be due to cancerous or non-cancerous, benign or malignant, or a stricture, which is diverticuli. Colorectal cancer is the third most common form of cancer. 9% of cancer deaths are due to colon cancer. It is more common in men. It's the highest mortality rate is with African American men and women. And the risk of contracting the disease increases with age. So the incidence of cancer along the bowel, as you can see, it is most prevalent in the ascending colon and in the sigmoid or in the rectum. Colonoscopies would be able to help to detect the presence of abnormal cells. Once they got the cells and they could study them, they could determine whether or not it was a cancerous cell. The risk factors associated with colon cancer are the diet of high processed meat and foods, fruits low in vegetables and fruit, and a sedentary lifestyle, obesity, physical inactivity, alcohol, and long-term smoking. The health factors related to it, the genetic conditions such as FAP. FAP stands for the acronym to say that they are more susceptible to the cancer cells. The personal history of irritable bowel disease. Irritable bowel disease is just when they have an inflamed bowel. The FAP actually stands for familiar adenomatous polyposis. It is found on page 954 in your high risk factors for colorectal cancer. Colorectal polyps. The polyps have the ability to change, and when they change, they can become a cancer cell and age. Adenocarcinoma is the most common form of colorectal cancer, and it's approximately 85% of it arises from a polyp. The tumor spreads through the wall of the colon into the muscular and the lymphatic and vascular system. The most common type of polyps are hyperplastic and adenomatous. Hyperplastic is your non-neoplastic growth, and they grow larger than 5 millimeters and never cause clinical symptoms. Other benign non-neoplastic polyps include inflammation polyps, lipomas, and juvenile polyps. This is an example of what the polyp looks like when you do endoscopies or colonoscopies. The cecum and colon carcinomas, as you can see, there's irregularity in the tissue, and this straddling is what is indicative of the cancer. The etiology and the pathophysiology. Unfortunately, one of the most common sites of metastasis is the lymphatic system. And once it enters into the lymphatic system, then it has the opportunity to embed itself into other areas, the liver, lungs, bone, and brain. The clinical manifestations, it's an insidious onset, very slow. They might not even observe, they just understand that they're a little more fatigued. And the symptoms might not appear until the disease is very advanced, which means they already might have metastasis before they're even aware that they have the disease. Some of the signs that they could are the change in bowel habits, either constipation or diarrhea, unexplained weight loss, vague abdominal pain, and symptoms of cancer in the left side of the colon appear earlier on the presentation. Symptoms of cancerous lesion is bleeding. One of the reasons why people seek medical attention is due to the fact that they now have bleeding. Alternating constipation or diarrhea, change in the stool caliber, which means the size becomes smaller, where it's more narrow and ribbon-like, and a sensation of incomplete evacuation, that they feel as if something remains in the rectal vault, and obstruction where nothing is getting through. They feel very weak and tired. They might be experiencing some iron deficiency anemia, and they might have occult bleeding. Again, occult bleeding is the bleeding which they are not familiar with. Bleeding can occur on both the right and left side. Bleeding on the right side, which is more common than the left side, is often unrecognized and is an early manifestation. Hematuria, fresh blood in the stool, is more often caused by left-sided colorectal cancer than right. Right-sided lesions are more likely to cause diarrhea, while left-sided are usually detected later and often present with bowel obstruction. Complications that can occur due to colorectal cancer are obstruction, which we're talking about today, because nothing can get through, bleeding, perforation, peritonitis, where the peritoneum becomes inflamed, and fistula formation. And fistula is a communication or an opening between one organ to the other. The abdomen is very, very firm, distended. They're having nausea, vomiting, and no bowel movements. Case study, GO is a 65-year-old man who was admitted for colon resection following a diagnosis of colorectal cancer. At the time of admission, he complains of constipation, bloody stools, abdominal pain, and weight loss. He's 6'1" and weighs 200 pounds, and he smokes a pack of cigarettes a day. So some of the risk factors that you can identify in his history is the smoking and the fact that he has experienced some constipation as well as bloody stools. Gio has a history of coronary artery disease and hypertension. He reports taking antihypertensive medication and 81 milligrams of aspirin daily. Gio wants to know how he got cancer and what risk factors does he have. So some of the risk factors you would have to share with him that he had was, we don't know if he had a first degree relative, tells you that he is very, very much at risk. The cigarette smoking that he mentioned is a risk factor that he has. He doesn't really tell you if he has any social history of alcohol. He doesn't mention whether or not there was a family member, and he certainly is not obese with he's 6'1" and 200 pounds. So the only really identifiable risk factor is culture and also his smoking history. So the signs and symptoms are based upon the location that the tumor is present. So if ascending will be more of a change in bowel habits and anemia. The transverse is pain, obstruction, change in bowel habits. On the descending side is where they might have the bright red blood in their stool. It's more located to the rectum, where if there's bleeding, it'll be present, and blood in the stool or change and rectal discomfort for the rectum. So the diagnostic studies, first would be a detailed history for the individual and the family. There is a very, very high correlation between family. Regular screening for polyps and cancer. So the flexible sigmoid is every 5 years, and that really is what provides them with the information. The gold standard is the colonoscopy, a double contrast barium enema study every 5 years, and a CT colonography every 5 years. Annual screening, fecal occult blood tests, where sometimes they're bleeding in their stool and they're not even aware about it because the blood is kind of hidden. Fecal immunochemical tests, otherwise known as FIT, would help to detect whether or not there is the presence of cancer cells. Tests for blood in the stool must be done frequently to catch intermittent bleeding that occurs with tumors. Sometimes a tumor is present, but it doesn't bleed all the time. So they could become confident that they don't have cancer, but it was actually a false negative. The FIT looks for blood in the stool. Stool tests can be done frequently, and you can detect that. In addition to testing for blood in human stool, there's new tests by Cologuard that can detect DNA mutations that might also predispose you to developing colon cancer. The colonoscopy is the gold standard. The entire colon is examined, and at the time of the study, they can also get cells for biopsies to study. The polyps can be immediately removed and sent to the lab for examination. Persons at risk need earlier and more frequent screening than the people at risk are those who have a first-degree relative, the father, the son, the brother, who were diagnosed with colorectal cancer at before the age of 60. Those with 2 first-degree relatives are even more considered higher risk. Colonoscopy and tissue biopsies are what needs to be done to confirm a diagnosis. Additional lab tests that might be looked at are a CBC looking for anemia, coagulation studies, PT and INR, to see if there's a bleeding history, and liver function tests. Your liver enzymes may also be looked at. CAT scan or MRI of the abdomen will help to see the METs. It is also helpful to determine whether or not there's liver metastasis or retroperitoneal and pelvic disease. and the depth of the penetration of the tumor into the wall. The CEA, the carcinoembryonic antigen, helps to determine whether or not is a complex glycoprotein caused by the CRC cells. It may be used to monitor for disease recurrence after surgery or chemo, but is not a good screening tool because of the large number of false positives. CEA levels may be increased in non-colon carcinomas, including gastric, pancreatic, lung, breast, and thyroid, as well as non-cancerous conditions such as irritable bowel, pancreatitis, cirrhosis, and COPD. So it is most beneficial to use to track how well someone is doing with colon cancer after it has been diagnosed, but it is not good for a diagnostic tool. The prognosis and treatment to correlate with the pathology and the staging of the disease is the TNM system. The TNM system is found on page 956 in box 42-3. And what it refers to is the primary tumor, the lymph node, the N is the lymph node involvement, and M is metastasis. The stages of colon cancer are by 0 stage if the cancer has not grown beyond the layer of the wall. 1, if it's grown into the layer. 2, if the tumor is through the wall but has not spread to the lymph nodes. 3 is to the lymph nodes, and 4, through the lymph nodes and at another site, distant site such as the liver or the lung. As you know, that the higher the stage, the worse the prognosis is. So typically what will have to occur is a surgical therapy. The goal of surgery is either complete resection of the tumor, let's just remove it, or a thorough explanation of the abdomen to determine if the cancer has spread. And the last is restoring bowel continuity so that the normal bowel function can return. And the 5th is preventing any surgical complications such as a wound dehiscence or infection. So the surgical management, the patient has to have very good preoperative care. Preoperative care would include to teach that they might possibly have a colostomy, what a colostomy is, how a colostomy would be managed. The polypectomy during colonoscopy is used to resect colon cancer in situ. That means the ones that are located right there. Whereas some polyps can be removed by colonoscopy to resect in situ and is considered successful when the resected margin of the polyp is free of cancer. The cancer is well differentiated and there is no apparent lymphatic or blood vessel environment. The decision for surgical treatment for colorectal cancer depends on the stage of the cancer and the location, and ability to restore normal bowel function and continence. Surgical removal of stage 1 cancer includes removal of a tumor and at least 5 centimeters of intestine on either side of the tumor, plus removal of nearby lymph nodes. The remaining cancer-free ends are sewn back together. That's called anastomosis, and they will not have to have a colostomy. Laparoscopic surgery is sometimes used for stage 1 tumors, especially those in the left colon. Low-risk stage 2 tumors are treated with a wide resection. Reastomosis and chemotherapy is used in addition to surgery for high-risk stage 2. Stage 3 cancers are treated with surgery and chemo. Radiation and chemo may be done before to reduce the size of the tumor and to debulk it. Once the cancer has spread to distant sites, any surgery is usually considered palliative and just used for treatment of pain. Decrease colon bacteria before surgery is important. This is one classification that will receive prophylactic antibiotics prior to surgery. And that is to prevent abscess formation. The bowel will be cleansed prior to. They're usually given go lightly orally if they can tolerate that, or cleansing enemas prior to surgery. Prophylactic antibiotics are given in order to help prevent surgical site infections. They are a common complication related to bowel surgery. Serious complications such as septicemia, which is infection of the blood, intra-abdominal infection, intercutaneous fistulas. Infections range from 30 to 60% without antibiotics and less than 10 when prophylactic antibiotics are given. The patient will have to be NPL. They usually have an NG tube to low wall suction until their bowel sounds return. They're on continuous IV fluids to prevent dehydration while they're on NPL. I and O, follow their labs, CBC, a basic metabolic panel, a PT, and an IR. As you know, the NG tube is from the ear to the nose to the xiphoid process, and it goes from the nose down into the stomach. The way you test for placement is you can test the gastric contents, and it is your responsibility to monitor the output and to make sure that the suction is not set higher than low wall suction. This is what an NG tube looks like. Patients generally do not like them. They're usually very, very miserable with the NG tube. Site of cancer dictates the site of resection, whether or not they'll have a right or left hemicolectomy. Stage 1 is removal of the tumor, cancer-free ends, and can be done laparoscopically. Stage 2, wide resection, but can still have reanastomosis. 2 is at low risk for stage 2 tumors plus chemo. Stage 3, surgery and chemo. 4 usually means that it's somewhere else and that the surgical is done for a palliative purpose. Chemo is directed to control the spread of cancer, and radiation generally to help with pain. Gio is going to have abdominal surgery for his stage 1 tumor. What is the priority care before surgery? Well, one of the priority cares would be to make sure he has his antibiotic, to make sure you can answer all questions. He should feel relatively positive in that the outcomes for stage 1 are pretty good. He may, reasons for temporary colostomy could be perforation, peritonitis, or hemodynamic instability, where the patient was very sick on the operative table and may need to have a temporary one in order for they were not able or did not have the time to close it. 3 surgical options in rectal cancer. They could have a local excision, low anterior resection to preserve the sphincter function. To preserve the sphincter function means that you are allowing the patient to still be able to manage their own stool. Abdominal perineal resection with a permanent colostomy. That usually means that so much of the bowel had to be removed in order to have the best outcome as far as cancer. These are the typical locations for a permanent colostomy. Again, wherever the colostomy is will thereby direct the nature of the stool, whether or not it will be very loose stool or will be more formed stool. This is an example of a colostomy, and you're looking, this is the stoma. It should be red and moist and pink, which demonstrates that it has good perfusion. This is an example of an ostomy bag that allows the patient to be ambulatory They could tuck that into their clothing and perhaps no one would notice that it was there. This is a prolapse colostomy where the bowel has protruded outward. As you can see, the color of it is red and moist. Prolapse colostomy are at risk of drying out because it's too much exposure to the environmental air. So it's very important that it's assessed at every shift to make sure it's still loose. These are some of the colostomy supplies. It is up to the registered nurse to make sure that prior to the patient going home, they feel comfortable with changing their bag, being able to empty their bag, being able to get their supplies. This is the part that goes on to the abdomen, and then this seals on like a lid to a bowl. The supplies come in various sizes, and that's due to the fact that everybody's abdominal cavity can vary a little bit, and their goals of care, like do they want to be ambulatory, do they go to work, how will they manage this? Some people are taught how to irrigate their colostomy. It is a cone shape that goes into the stoma. Then there is fluid. The fluid is directed into the stoma, and it is at a rate that the patient can tolerate. If the patient has it going in too fast, then they might get some cramping, and you would just have to slow it down. This is an example of a colostomy. Sometimes they need two stomas, and it would be liquid stool that comes out, and your responsibility is to empty it. Chemotherapy can be done prior to surgery in order to shrink the tumor. It is primarily dictated for tumor sizes 3 and high risk tumors, or if the patient is not an operative candidate, palliative treatment for the tumor could be done with chemotherapy. 5-FU plus folic acid, folinic acid, leucovorin is used alone or in combination with Alexin. Alexin is preferred if patients can tolerate the side effects. The case study. Gio is very upset. He has many questions about his diagnosis and his upcoming surgery. What interventions are appropriate to help alleviate his stress? Well, I really believe that the first thing that you should do when you have someone going to surgery that is very worried is to give yourself enough time in order to teach them. If you are rushed and you are feeling very hurried, they're going to sense that, and that will increase their anxiety. First, determine what his questions are. Answer anything you can, and if you're not able to, see if you could get the surgeon or someone who is better equipped to answer the questions. Radiation therapy could be used post-operatively. They don't typically like to do it pre-operatively because it can damage the skin. It's used as an adjunctive with surgery and chemo. It's palliative therapy for metastasis in that it can help to reduce the tumor and to provide symptomatic relief. So it's very important that you do a thorough nursing history, which includes asking, Gio is a male, so you would want to know if there has been any females that have had any breast or ovarian cancer, any history of polyps or inflammatory bowel disease. What medications he's been on, has he experienced any weakness or fatigue, change in bowel habits, does he have a high calorie, high fat diet, any increase in flatus or feelings of incomplete evacuation. What does Gio need to know about how smoking can affect his health? It is very difficult because you don't want them to feel as if they're being punished, but smoking can have a hazardous outcome. It can also contribute to metastasis. This information has to be shared with him. The nursing diagnoses associated are diarrhea and constipation, fear, anxiety, ineffective coping, and if they need a colostomy, a change in body image. Their overall goal is to return to a normal elimination pattern. The quality of life is appropriate to disease progression and relief of pain and comfort and well-being. Health promotion. You want to encourage anybody older than 50 to have regular colon cancer screening. Participate in early cancer screening will help to decrease their mortality, and realize that fear and lack of information can cause some barriers to prevention exercise activities. Colonoscopy, detect the polyps only when the bowel has been adequately prepped. That means that if you have a lot of stool in the bowel during colonoscopy, they won't really be able to visualize all the polyps. Provide teaching about bowel cleansing and correctly administered prep. The acute intervention, anticipate pre-op needs for the patient with extensive surgical intervention. Consult wound and ostomy. They may be able to provide some more information about the ostomy and to provide some follow-up care and teaching. Post-operatively, the dressing change has to be done sterile. You're assessing for any signs of infection. There could be a high incidence of it. You're going to take care of the drains, the patient, the caregiver teaching about the stoma, and management differs depending on the type of wound. Post-operatively, they could have drains, and you should monitor the output and assess the color and the consistency. Wound should be thoroughly examined for any excessive drainage or odor. Monitor the suture lines, help with pain control, and provide education for sexual dysfunction. What should you teach Gio's wife and family in regard to his post-op healthcare needs? I always try to tell them to be patient, that they're not going to have the energy that they typically have, that they might have some fears about what is happening to them, and provide them with meticulous wound care. Ambulatory and home care, psychological support, chemotherapy may be ordered. They would need to know where they have to go and what time. And perineal wounds may not be completely healed upon discharge and must be taught wound care. Your expected outcomes are to have minimal alteration in bowel, have a balanced nutritional intake, and relief of pain. The quality of life is appropriate to the disease and feelings of comfort and well-being. What follow-up care will Gio need once he has healed from his surgery? He will have to go back to have his wound assessed. Once he has been released from the surgeon, he will have to follow up with his primary care and continue to have screenings for colorectal cancer. The end. Any questions, please let me know.